So, dear audience, my name is Regina Molnár, and today I would like to present you our research on abnormal glucose tolerance in cystic fibrosis. I'm a PhD student and a resident doctor working under the supervision of Andrea Párniczky and Clementina Ocskai. Here you can see our two ongoing projects which investigate potential risk factors of early onset abnormal glucose tolerance. And why did we choose this topic? Because CF-related abnormal glucose tolerance is the second most common extrapulmonary complication of CF, affecting 1/3 of adolescents, half of adults. This is a spectrum where CFRD is the most severe form, and although annual oral glucose tolerance testing is the gold standard method for screening from the age of 10, the onset of abnormal glucose tolerance varies greatly. Some patients develop it in early childhood, while others maintain normal glucose tolerance until adolescence or even later. So our question was, what could be the reason behind this? In type 1 diabetes, the TEDdy study showed that combining the screening of antibodies, a genetic risk score, and family history of diabetes improves prediction. However, in CF, these potential markers are still underexplored. According to current guidelines, the screening of antibodies is only recommended in special cases, and even then with a low level of evidence, therefore it's not widely applied. Regarding family history of diabetes, previous studies were inconclusive, although recently Blackman and colleagues showed that nearly threefold increased CFRD risk is observed with patients with positive family history, but still guidelines don't suggest screening. So with our first project, our aim was to assess one of these potential risk factors, antibodies, and we did it by conducting a systematic review and meta-analysis. Here you can see our clinical question, which included CF patients with antibody measurement, and we looked for their age of onset and the presence of the listed antibodies, and our hypothesis was that these antibodies are present in abnormal glucose tolerance. Our systematic search yielded 20 studies, and we calculated prevalences and odds ratios with 95% confidence intervals, and here's a list of all the analyzed outcomes. Let's jump to the results, and this first aggregated forest plot, which shows the pooled prevalence of antibody positivity in people with CF. Prevalence ranged from 1 to 6%, with islet cell antibody being the lowest and insulin antibody the highest. 4% of CF patients had any kind of positivity, and just 1% had multiple positivity, which is likely underestimated due to inadequate reporting. The heterogeneity was high in this analysis due to 2 outlier studies with technical issues in antibody measurement, and risk of bias was high. This next plot shows the prevalence by glycemic status, where we divided patients into diabetic and non-diabetic ones. And we can see that the CFRD group exhibited higher prevalences by 1–2% across outcomes, but this tendency was without statistically significant difference, non-significant. So it was a non-significant difference, sorry. So we wanted to test it from a different point, and odds ratios of antibody positivity were calculated between CFRD and non-CFRD patients. And the odds of antibody positivity range from 2 to almost 5, and was consistently and statistically significantly associated with CFRD, with strongest association found for gut positivity. The systematic review part revealed that an abnormal glucose tolerance presented earlier and with more complications in antibody positivity. So the strengths of this study are the use of odds ratios and comprehensive assessment of several antibodies, but we have limitations, which include the high risk of bias, the heterogeneous results, and the lack of longitudinal data on antibodies. So our conclusion is that antibodies are present in 1 to 6% of people with CF, and despite the low prevalence, antibody-positive individuals, antibody positivity is associated with CFRD, earlier onset, and complications. So our implications for practice based on these, that the routine screening is not justified, but closer monitoring for antibody-positive individuals is needed. And for future research, it should focus on improving risk stratification methods and provide uniform and longitudinal data on antibodies. This work has recently been published in the Journal of Cystic Fibrosis, which we are very happy for. Let's move on to this second project, where we are analyzing our pediatric cohort with the registry analysis. As previously described, in CF we lack information about risk factors of early onset abnormal glucose tolerance. So with our second project, we aimed to assess antibodies and family history of diabetes as well in this regard. We studied children with cystic fibrosis in terms of antibody positivity and family history of diabetes, and looked for their glycemic status, and hypothesized that abnormal glucose tolerance is associated with these risk factors. We conducted a cross-sectional analysis of 78 children with cystic fibrosis from the CF-related pancreatic disorder registry, which includes more than 130 patients total and the biobank as well. The following 4 antibodies were analyzed with a standardized ELISA kit, and family history of diabetes was collected with a structured questionnaire and evaluated based on 2 different criteria, which you can see here in the table. There was a 2-dimensional which defined positivity with at least 1 first-degree relative with diabetes, and the 3-dimensional approach was broader. It had an additional possible category as well. The glycemic status was based on oral glucose tolerance test results. I would like to show you some preliminary results of this project. This is a table about the basic characteristics of the study population by glycemic status. About 55% of the population were boys and 77% were on CFTR modulator therapy. The overall median age was 8.7 years, and CFRD kids were significantly older, but this is consistent with the non-age-related increase in CFRD prevalence, so it did not surprise us. This figure shows the prevalence of antibody positivity by glycemic status. For the definitions of any single and multiple positivity, look at the top right corner of the slide. And what we can see here is that any and single positivity were significantly more frequent in kids with CFRD. Of note, only 2 children had multiple positivity and they did not have diabetes. This next figure shows the antibodies by type. And we could observe different antibody profiles in CFRD and non-CFRD. Some antibodies like islet antigen 2 and insulin antibody were non-significantly more common in CFRD, while others like GOD and zinc transporter only appeared in non-CFRD. And last but not least, about the family history of diabetes, evaluated by the previously described 2 criteria. There were similar prevalence rates of positive family history of diabetes in CFRD and non-CFRD in our cohort for both criteria, so we couldn't observe the significant difference. The strengths of this study are the comprehensive assessment of 4 different antibodies, including single and multiple positivity as well, and the subgroup analysis by glycemic status. But our major limitation is the cross-sectional design, that antibodies were measured at a single time point and the genetic testing was not available. So our preliminary conclusion is that antibodies are more frequent in CFRD. However, family history of diabetes shows no significant association. So our implications for practice, again, is that the routine screening is not justified based on these data. But we have more implication for research, which include a longer follow-up, repeated antibody measurements, which we are currently working on at the clinic. And of course, the dream would be to provide a personalized risk score to improve early detection and management of children with CFRD. So together, our connected projects explore different and potential risk factors of early onset abnormal glucose tolerance, first focusing on antibodies on international level, and this is an extended second project adding family history of diabetes to the picture. Fortunately, we have had the chance to present our findings on national and international conferences. And I would like to express my gratitude to the CF team at the clinic and the children and families who participated in the registry. And thank you for your kind attention. With the words of Jesler, children are not things to be molded, but are people to be unfolded.
Thank you very much, and thank you for the good time management. And then now let's open for discussion from the audience. Anyone has a question, an ice-breaking question? Than I have. In the meantime, you are thinking on the question. So you mentioned the TEDdy study, which is a very good a basis for the establishment of the gut microbiota deficiency and type 1 diabetes and pancreatic and autoantibodies. So do you think that your project is related to the previous presenter's project, stating that when there is a deficiency of the normal gut microbiome, then you have a higher chance to have self-immunity and cause issues?
Thank you for your concept and question. Yes, I think there is a close relation with dysbiosis and triggering autoimmune responses. And of course, these 2 projects are connected because they are based on the same registry and the same concept, but exploring different points, I think. So, of course, in the further exploring of additional factors, this biopsies could be one as well.
Yeah, that's cool. And then what do you think, what can be the mechanism behind all these observational data? That what might link really your cystic fibrosis to the diabetic outcome and the dysbiosis? Do you have any hypothetical mechanism?
Well, cystic fibrosis is a multifactorial complication of CF, which are, as I previously explained, not well studied. Of course, the advanced age is a risk factor, pancreatic insufficiency as well. And regarding my topic, the bystander theory of islet autoimmunities as well. And regarding dysbiosis, of course, it has a connection with antigen presentation as well. So this both have the underlying mechanism of triggering an autoimmune response.
Thank you very much. So now questions.
Thank you for this great presentation, and it's a really great impact on the clinical decision make, because the protocol, which is about the pancreatic antibodies screening in childhood, is under development. So they will be announced soon, hopefully, and this is also give some good remarks for this topic. But maybe you can tell us which patient population must be already recommended to screen these pancreatic antibodies, and why?
Yes, sorry. So thank you for your question. The special events in this regard and the guideline means when the abnormal glucose tolerance presents before the age of 10. Because this is the cutoff now for starting screening, or when it presents with an acute complication, for example, diabetic ketoacidosis, or if there is an immediate history of autoimmunity in the family or a personal history. So, for example, the child has like celiac disease or other autoimmune diseases. So this is the recommendation currently, but we are seeing the data, and it suggests that screening should start earlier. And I think this is the major point, because there are these kids who develop abnormal glucose tolerance before the age of 10. And what's the most important part of this is that CFRD is connected with other complications. So, for example, decline in pulmonary function, increased morbidity and mortality. And these could be, well, if not prevented, but earlier managed, which improves these as well.
Right. Thank you. You mentioned the celiac disease is also a recommendation. And according to some literature, in cystic fibrosis, celiac disease can have a higher prevalence rate.
Yes.
Somebody of your patient population have celiac disease, because celiac disease is also a risk factor for type 1 diabetes.
Yes, it's a very good point. One of our members from the study groups did research on this project about the additional autoimmune diseases presenting in cystic fibrosis, and they did have a higher prevalence in this population. And I don't know the exact number of the patients who have celiac disease, but it's elevated.
But in your population?
In our in our population, I think about 10 kids at least have a celiac disease.
Okay.
Thank you. Very interesting and very good to the previous talk, so that I, as non-CF expert, can get more into the topic. I was wondering, is there any correlation of exocrine function and the endocrine function and parameters that you monitor?
So about so most of the study population had a pancreatic exocrine insufficiency. So for example, in the CFRD group, there are only 2 kids who had a sufficient exocrine pancreas. And the main theory in CF is that this structural damage to the pancreas is the main cause with insufficient insulin. And there is also a decline in first phase insulin response, and these are the major factors in developing CFRD. So exocrine pancreatic dysfunction is one of the major factors. And I don't know if I got the second part of the questionnaire.
No, that's already it. So do you think with the modulator therapy,
Yes.
you may be also able to improve
Yes.
this autoimmune effects?
Excellent point, and thank you for raising this. Yes, our hypothesis is that CFTR modulator can improve even the endocrine pancreatic dysfunction as well. So there are only preliminary studies on this, but they suggest that those children who are on modulator improve their glycemic status. So there are some promising results regarding this.
Thank you.
Thank you for your presentation. There were a lot of talk about prevalence and odds ratio. So my question would be, which one did you choose and when? And why?
Yes. So the prevalence was chosen for the presence or the absence of the islet antibodies. And the odds ratios were calculated by our great statistician based on the presence or the absence of these events. And we chose it because of the rarity of the events. And well, that's why.